Okay, this is ATI Nutrition Chapter 10, Total Parenteral Nutrition. Parenteral nutrition, or PN, is used when a client's gastrointestinal tract is not functioning or when a client cannot physically or psychologically consume sufficient nutrients orally or enterally. Based upon the client's nutritional needs and anticipated duration of therapy, PN can be given as either total parenteral nutrition, which is TPN, or peripheral parenteral nutrition, which is PPN. TPN provides a nutritionally complete solution. It can be used when caloric needs are very high, when long-term therapy is indicated, or when the solution to be administered is hypertonic, composed of greater than 10% dextrose. It can only be administered in a central vein. PPN is administered for 7 to 10 days into a peripheral vein. It is nutritionally incomplete because it has a low dextrose content. It is indicated for clients who require short-term nutritional support with fewer calories per day. The solution must be isotonic and contain no more than 10% dextrose and 5% amino acids. Components of parenteral nutrition solutions. PN includes amino acids, dextrose, electrolytes, vitamins, and trace elements, and sterile water. Fats or lipids are added to the parenteral solution or given as an intermittent infusion. Carbohydrate or dextrose solutions are available in concentrations of 2.5% to 10% for PPN and up to 70% for TPN. A higher concentration of dextrose is often prescribed for a client on fluid restrictions. A lower dextrose concentration can be used to help control hyperglycemia. Electrolytes, vitamins, and trace elements are essential for normal body functions. The amount added are dependent upon the client's blood chemistry values and physical findings, which are used to determine the quantity of electrolytes. Additional vitamin K can be added to the PN solution. Lipids or fats are available in concentrations of 10, 20, and 30%. Lipids are formulated from a combination of soybean oil and or safflower oil and egg phospholipids, which gives lipids a milky or opaque appearance. IV lipids are contraindicated for clients who have severe hyperlipidemia, severe hepatic disease, or an allergy to soybean oil, eggs, or safflower oil. Lipid emulsion provides the needed calories when dextrose concentration must be reduced due to fluid restrictions or persistent hyperglycemia. They also correct or prevent essential fatty acid deficiency. Lipid emulsion provides the calories without increasing the osmolality of the PN solution. Total nutrient admixtures are available that combine lipids into the PN solution containing dextrose and amino acids, rather than administering the solution separately. Not all facilities use this 3-in-1 solution. 3-in-1 infusions reduce body carbon dioxide production and buildup of fat in the liver. Protein is provided as a mixture of essential and non-essential amino acids and is available in concentrations of 3 to 20%. The client's estimated requirements and liver and kidney function determine the amount of protein provided. Other substances can be added to the PN solution by pharmacy services. Insulin can be added to reduce the potential for hyperglycemia. Heparin can be added to prevent fibrin buildup on the catheter tip. Glutamine antioxidants, prebiotics, or probiotics might be prescribed based on individual client needs. Administering any IV medications through a PN IV line or port is contraindicated. Indications. Diagnoses. TPN is commonly used in clients who need intense nutritional support for an extended period, including clients undergoing treatment for cancer, bowel disorders, those who are critically ill, and those suffering from trauma or existing extensive burns, as these conditions are associated with high caloric requirements. PPN can be used when the client is unable to consume enough calories to meet metabolic needs or when nutritional support is needed for a short time. Clients can receive PN at home as nutrition replacement or to supplement nutrition. Typically, the client will have a tunneled catheter and feedings can occur while the client sleeps. Desired therapeutic outcomes. Improve nutritional status, weight maintenance or gain, positive nitrogen balance. Evidence supporting effectiveness, daily weight, maintenance of baseline or gain up to 1 kilogram a day. Increases in prealbumin level. Expected reference range is 15 to 36 milligrams per DL. Blood urea nitrogen level within the expected reference range of 10 to 20 milligrams per DL. Considerations. Preparation of the client. Prior to initiating PN, review the client's weight, BMI, nutritional status, diagnosis, and current laboratory data. This can include CBC, blood chemistry profile, a PT or APTT, iron, total iron binding capacity, lipid profile, liver function test, electrolyte panel, BUN, prealbumin and albumin level, creatinine, blood glucose, and platelet count. Assess the client's educational needs. Use an electric infusion device to prevent the accidental overload of a solution. A micron filter on the IV tubing is required when administering PN solution. This filter is not added to the IV tubing when administering a lipid emulsion. Evaluate for allergies to soybeans, safflower, or eggs if lipids are prescribed. Ongoing care. Nursing care is focused on preventing complications through consistent monitoring. Specific monitoring guidelines vary among healthcare facilities. Parameters can include I&O, daily weights, vital signs, pertinent laboratory values, for example, electrolytes, and evaluation of the client's underlying condition. This data is used to determine the client's response to therapy, whether the formulation of the solution is correct, and to prevent nutrient deficiencies or toxicities. Monitor blood and urine glucose as prescribed and per facility guidelines. Sliding scale insulin can treat or prevent hyperglycemia, or regular insulin can be added to the PN solution. Monitor flow rate carefully. Administering the solution too slowly will fail to meet the client's nutritional needs. Administering the infusion too rapidly can cause hyperosmolar diuresis, which can lead to dehydration, hypovolemic shock, seizures, coma, and death. To avoid hypoglycemia, an IV of dextrose 10% to 20% in water is administered to the PN solution is unavailable. Do not attempt to increase the rate of the PN solution to catch up. Hyperglycemia, hyperosmolar diuresis, and fluid overload can occur if the PN solution is increased when available. Monitor for cracking of TPN solution. This occurs if the calcium or phosphorus content is high or if poor salt albumin is added. A cracked TPN solution has an oily appearance or a layer of fat on top of the solution and should not be used. Verify the prescription of the PN solution with a second nurse prior to administration. If the PN solution is prepared and stored in the refrigerator, allow it to come to room temperature for 1 hour prior to administering it. Maintain strict aseptic techniques to reduce the risk of infection. The high dextrose content of PN contributes to bacterial growth. Use sterile technique when changing central line dressing and tubing. Changing the bag and IV tubing for the dextrose solution every 24 hours unless facility policy differs. With intermittent IV lipid infusions, ensure the solution does not hang more than 12 hours to prevent microbial growth. Ensure lipid infusion is stopped 12 hours prior to obtaining a blood specimen for triglycerides to ensure accurate results. Nursing actions. Ask the provider about giving some enteral substance during long-term PN administration, such as diluted juice, to prevent atrophy of the gastrointestinal tract. PN should be discontinued as soon as possible to avoid potential complications, but not until the client's enteral or oral intake can provide 50 to 75% of estimated caloric requirements. Discontinuation should be done gradually to avoid rebound hypoglycemia. During transition, the client will need enteral or oral nutrition. Oral nutrition usually begins with clear liquids that are low in fat or substances that might irritate the client's gastrointestinal tract. The client might not have an appetite for 1 to 2 weeks, so PN infusion will need to continue until the client can take in adequate calories through other means. Educate the client and family regarding home PN, including aseptic preparation and administration techniques. blood glucose monitoring, and criteria to evaluate for complications. Complications, infection, and sepsis are evidenced by fever or elevated white blood cell count. Infection can result from contamination of the catheter during insertion, contaminated solution, or a long-term indwelling catheter. Metabolic complications include hyperglycemia, hypoglycemia, hyperkalemia, hypophosphatemia, hypocalcemia, dehydration related to hyperosmolar diuresis resulting from hyperglycemia, and fluid overload as evidenced by weight gain greater than 1 kilogram a day and edema. Mechanical complications include catheter misplacement resulting in pneumothorax or hemothorax evidenced by shortness of breath, diminished or absent breath sounds, arterial puncture, catheter embolus, air embolus, thrombosis, obstruction, and bolus infusion due to an incorrectly set or malfunctioning electronic pumps. Refeeding syndrome occurs when the body rapidly changes from catabolic, seen in starvation states, to anabolic metabolism when nutrition is started. It is characterized by fluid and electrolyte imbalances, potassium, magnesium, and phosphate. Manifestations include shallow respirations, confusion, seizures, weakness, cardiac rhythm changes, fluid retention, and acidosis. Nursing actions. Monitor for manifestations of fever, chills, increased white blood cells, and redness around the catheter insertion sites. Use strict aseptic technique when setting up the IV, tubing, changing the site dressing, and assessing or deassessing the IV access. Change the PN bag and tubing every 24 hours or per facility protocol. Monitor blood glucose per prescription or facility policy. Administer sliding scale insulin or plan for insulin to be added to the TPN solution to treat hyperglycemia. Plan to administer additional dextrose to treat hypoglycemia. Monitor daily weights, I&O, and oral intake of nutrients. Notify the provider of weight gain greater than 1 kilogram a day. Anticipate a decrease in the concentration of the solution, rate of administration, or volume of lipid emulsion to treat weight gain. Okay, a charge nurse is providing information about fat emulsion added to total parental nutrition, TPN, to a group of nurses. Which of the following information should the charge nurse include? This is concentration of liquid emulsion can be up to 30%. Adding lipid emulsion gives the solution of a milky appearance. Check for allergies to soybean oil. Lipid emulsion prevents essential fatty acid deficiency. A charge nurse is teaching a group of nurses about medication compatibility with TPN. Which of the following statements should the charge nurse make? Regular insulin can be added to the TPN solution. A nurse is preparing to administer lipid emulsion and notes a layer of fat floating on the IV solution bag. Which of the following actions should the nurse take? Return the bag to the pharmacy. A nurse is caring for a client who is receiving TPN through a central venous access device, but the next bag of solution is not available for administration at this time. Which of the following actions should the nurse take? Administer 20% dextrose and water, IV, until the next bag is available. A nurse is planning care for a client who has a new prescription for peripheral parental nutrition, PPN. Which of the following actions should the nurse include in the plan of care? Examine trends in weight loss, review prealbumin finding, use IV tubing with a micron filter, and use an IV infusion pump.